Okay, KAWP listeners, today we are going to be interviewing Dr. Michael Antimisiaris. And Dr. A is the chief cardiologist at the Pikeville Hospital Heart Institute. And today we'll be talking about the evolution of pacemakers. We'll be talking about different types of arrhythmias that people experience. Things that can be done to cure certain types of arrhythmias, medications that can be taken, also kind of the future of implantable pacemakers and the possibility of not even having wires. So please enjoy today's podcast, and hopefully you'll learn something. Well, today I am honored to be with Dr. Michael Antimisiaris.
Very good.
Okay, for the linguistically challenged,
yes.
Dr. A.
Dr. A, that's me. Yeah.
Dr. A, thank you for being here, first of all.
Oh, it's my pleasure.
Secondly, you are an electrophysiologist.
That's right.
Okay. Would you mind telling our listeners what that is and what you do?
Well, it's really a subspecialty of cardiology. So after you get your general cardiology training, you subspecialize in electrophysiology, which is really the study of the electrical system of the heart. And as such, we're pretty much dealing with things from the very mundane, like people who have palpitations or skip beats, to the very severe or life-threatening, like survivals of sudden cardiac arrest.
Okay.
And we're dealing with all these arrhythmias in between. So it can start from a very benign but symptomatic, more of a nuisance thing,
Okay.
and it goes all the way to the life-threatening. And we intersect with a lot of, and that's our intersection with your, with athletes get a lot
Sure.
of arrhythmias, and there's always a fine, and now we're recognizing more about this, but there's really a fine distance between what we used to call an athletic heart and a pathology associated with that.
Now, I think people find it interesting that the heart has its own electrical system. Is that correct?
Well, it is very interesting, and it's obviously very intriguing, and because as humans we've dealt with electricity for some time, and a lot of things that we learned by dealing with electricity we were able to bring into the heart and deal with different heart ailments. For example, you can think of patients needing pacemakers as having a problem with the electrical cabling in the heart.
Right.
And so the pacemaker wires essentially replace that. And it's we do a very small part of the job. The heart is a regenerative organ, so if we apply a small electrical impulse, the heart takes it and delivers it to the rest of the heart. So we can stimulate a very tiny area of the heart with an electrical wire with a voltage of a 5-volt battery.
Okay.
And we're able to stimulate it and capture the whole heart and produce an electrical impulse that way.
Okay.
And that knowledge and that development has led us to be able to miniaturize cardiac pacemakers and cardiac devices and implant them, and that's going now to the next step, obviously. But
the evolution of medicine is fascinating, but do we know all there is to know about the heart, or is there still a lot of...
Absolutely not.
Okay.
We know a lot, and it's like Rumsfeld once said, we know what we know, we know what we don't know.
Right.
And now, so we know that we don't know a lot, but beyond that, there's a lot we don't know that we don't know that we don't know.
Gotcha.
Or that we think we have right and we don't.
Right.
So things are changing all the time. There's new developments from the field of genetics, for example. We're getting new diseases, for example, muscular dystrophy,
Right.
and how it affects the heart, amyloidosis and how it affects the heart, and treatments for those disorders are just starting out right now.
Okay. Well, fascinating. I wanted to talk to you a little bit about the evolution of some of the technology. We know that technology and medicine are very integrated with each other. Now, when you first started in your practice, I'm sure the pacemaker technology was at a level that it's not at today. Can you talk to me a little bit about the evolution of the pacemaker from where it was to where it is today?
Yeah, so I've been doing this for about 30 years, and probably put my first pacemaker in about 30 years ago.
Okay.
And obviously the devices were much larger. The technology of the leads was much different then. The longevity of the devices was much less so then. And so that started about 30 years ago. We didn't have any kind of sensor technology, which if we want to supply what we call physiological pacing to a patient, we're trying to reproduce what is the electrical system of his heart does. And the most physiologic pacing is if we can pace the top of the heart and let the conduction system of the heart do the rest of the job. So if the patient just has a slow heart rate,
right,
but intact cabling, intact conduction from the top to the bottom of the heart, we can pace the top of the heart. The thing about the top of the heart as compared to the bottom, it's a very thin structure. Electricity travels through it very quickly without the need for a specialized conduction system. So you can pace anywhere in the top of the heart and achieve the same kind of contraction that a normal heartbeat gives.
Okay.
The bottom is totally different. If we pace the bottom of the heart, the ventricles, where the main pump function is, from one point and let it travel to the rest of the heart, it would take a much longer time to travel compared to the normal heartbeat. So there's a specialized conduction system at the bottom of the heart that we are not able to reproduce with pacing. So that's one part that we can improve on, and we're still trying to improve on. The second part is in patients that we're pacing and are dependent on pacing or have a fixed heart rate. How do you change that rate from a resting heart rate to what they require when they're exercising?
Right.
And that technology has evolved a lot. So we are able to put sensors in the pacemaker that either detect motion, activity, or some other physiological parameter, and are able then to, through an algorithm, increase the heart rate to try to match what a normal heart under that influence of that kind of activity should have.
Right, and those are the rate adjustable pacemakers.
Rate adjustable pacemakers.
Is that the state of the art that we have right now?
Well, we have a lot of different sensors that there probably some room for improvement, but pretty much we've garnered most of what we can.
Right.
From what available technology we have right now.
And one of the things that I think their listeners need to understand is that not every patient that comes through your doors is an elderly person that just has a degenerative issue with their heart, that you may have a fairly young person that's coming.
Right, and in fact those are the toughest ones sometimes to try to program a pacemaker to, because the elderly person has much less variation in heart rates that they require. For example, they might need a resting heart rate of 60 to 70, and their maximum effort heart rate may be 110 to 120. If you take a young person, they might require a heart rate between 60 and 200, with activity, and that would be their norm. So it's much more difficult to tailor that patient than it is the elderly patient.
And that's part of what you do. I mean, you can change settings within
and
the
as
pacemaker.
you know, some of the most challenging cases are the ones that want to exercise, the ones that want to keep doing what they're doing.
Is it safe to exercise with
absolutely?
I mean, everybody's different, but I mean, in general,
it should be very safe to exercise with pacemakers, and any kind of activity really is safe.
Now, I'm finding people who have pacemakers that are exercising are getting close to what I would almost think if they didn't have a pacemaker, they're achieving results that are very similar. I mean, it's quite amazing.
We're able to restore them back to where they would be if they had a normal cardiac conduction.
So their quality of life is really
should be what it was before, with the caveat that they need some maintenance for the pacemakers. They're not maintenance-free devices. We need to check them so often. The weak link there is the wires that go from the pacemaker pocket or the device itself to stimulate the heart.
Right.
And that's being addressed with the next generation of pacemakers.
Do you think there's ever a time, I mean, cars, things like that are kind of fly-by, no wire? In other words, you have a sensor, but you don't have to have a hard-wired...
That's coming. Now, the first step to that is we've developed miniaturized devices that actually get implanted directly inside the heart.
Oh.
So we have a pacemaker, and that can be a quarter of a centimeter in length or half a centimeter in length, and can provide 12-year battery for a single chamber pacing. So we've already implanted many of those. They're called leadless pacemakers.
Okay.
So the generator itself and the lead, the whole system is miniaturized into a small body that gets implanted through the vein into the groin and goes into the heart and hooks into the heart muscle and just stays there.
Right.
We're able to interrogate it from the outside and reprogram it. It still has a sensor, surprisingly enough. It's an accelerometer. It's a little piezoelectric crystal. So that is for patients that only require one chamber pacing.
Okay.
But I can't imagine a patient who requires a one chamber pacing now that I would do a conventional pacemaker and not this kind.
Okay.
Because it's less risky.
Right.
It's quick, and frankly, it removes the weakest link, which is the long wire that has to be implanted from the vein that returns blood from the upper extremity to the heart. So all that length, that 58 centimeters of length of that wire, is the weak link because it has to withstand the motion of the heart. Every heartbeat, it has to pull and move around and torsion, and there's hundreds of thousands of those. So it's like pulling and pulling on those wires, pulling and pushing and turning around.
And they have to be replaced from time to time, is that correct?
And they do have to be replaced because they can't last forever, and that's still the weakest link there. This removes that from the equation totally.
So that just makes it easier on the patient, less times that they have to...
Easier on the patient. You don't even see a scar. You can't tell that they have a pacemaker.
Wow.
It wouldn't even be detected at the airport in a walkthrough. And because the antenna is inside the heart, there's no big antenna to field signals from the outside world, they're actually better protected. There's less likely to have any external interference with those.
Wow. Now, you are talking about kind of, I think, the pacemaker in the next generation. Do you think that there's anything in the future that's even...
Well, you even said this wireless stimulation. So I think there's going to be a time that we're going to be able to remotely pace the heart.
Wow.
Yeah. So with some targeted, probably there'll be a field generator. Now that's about 20, 30 years down the line.
Okay.
But we still have a lot of advances with these so-called leadless pacemakers, but they still need contact with the heart itself. Right. There's going to be a time that we could probably implant something subcutaneously over the heart and have some kind of targeted field that's able to pace various spots in the heart and maybe do multi-site pacing, more physiological pacing than we're able to right now.
Well,
that's almost science fiction.
I was just getting ready to say that's almost sci-fi
fiction.
stuff.
Yeah.
Now you're lucky that you're in a field where a lot of physicians either they do maintenance on patients, they try to make the symptoms less, or they try to slow down a progression of a disease.
Right.
But you're in a field where you actually get to cure some patients with ablating and things like that. Now,
right.
Tell me a little bit about the ablating and where that has been and where it's going.
Well, so ablation is a field, so we're able to tackle more kinds of arrhythmias with ablation than we used to. The gold standard when I was, and I've been doing this for 30 years, the field's about 30 years old.
Right.
So I've seen it all. But when we first started, our big excitement was patients with Wolff-Parkinson-White syndrome because they had arrhythmia, they had rapid heart rhythms, and they had an abnormal EKG, what we call a delta wave on EKG. And we were able to ablate. This was an extra electrical connection between the top and the bottom of the heart. We were able to map where it's coming from. And it's really just mapping out electrical pathways, pacing from one spot, seeing where the electricity gets through, and finding the appropriate location to apply a small radiofrequency current that heats up the tip of our catheter and causes a small burn.
Right.
And the impressive thing about that, and what still to this day is sort of our magic moment. So the magic moment for the electrophysiologist is applying the radiofrequency energy and within 1 second, within one beat, seeing the delta wave go away. And that patient's cured for the rest of his life.
Right.
Unfortunately, now the pediatric electrophysiologists are getting all those patients and we don't see as many anymore. So the less magic moment is people who come in with supraventricular tachycardia, have repeated episodes. We're able to ablate those. It's not as dramatic. We don't see any change on the surface EKG. but we fix the problem.
Right.
It's a hidden cable, basically, and we fix it, and we can't tell right away, hey, it's gone, we fixed it. But when the patient comes back in a few months and said, you changed my life, that's it. So those two, arrhythmias are pretty standard treatment, able to fix them. Other things not quite as easy. For example, PVCs, or ventricular ectopic beats, we're able to fix, but it's a little more troublesome. It's not 100%. And
will they move around on you sometimes?
Sometimes they move. Sometimes we fix the spot and then they come back a year or two later with a different spot. And it's a little more tricky. And the bigger problem that we have, and that what keeps us busy the most, is atrial fibrillation, which is a disease that has sort of an early and a late pattern of onset in patients. And the early patients that are predisposed to it genetically, and we catch early, we can fix them. But the problem is, if we fix them in their 30s and 40s, they still have a risk of coming back, when we all have a risk of developing that. So there's two parts. It's a genetic disease and it's a degenerative disease. And any kind of predisposing factor for cardiac disease would be a predisposing factor for atrial fib, like hypertension and diabetes and caffeinated intake and stuff like that.
With AFib, I guess that's when I talk to people, they talk about AFib as kind of the one that's the most difficult to live with. It's the most difficult maybe to be treated.
Right.
But there are new medications that are out there now.
There are new medications. We have new blood thinners. So the big risk of atrial fibrillation, and the one we're trying to prevent, is it causes stroke, and it's the one cause of stroke that's preventable if you treat the patient with blood thinners.
Right.
So it's a big part of what we're trying to do. We're trying to find those patients and at least get rid of that risk. In addition to that, it's the symptoms of the disease itself, the sudden palpitations. That we have some drugs. Our drugs have not been traditionally good for that. Then they have a lot of side effects, and in some instances they're risky. Right. So in fact, a lot of times I would think that an atrial fib ablation in a younger person is much less risky than giving that patient some of these drugs for the next 10 or 15 or 20 years, and a much better success rate. So we have things we can do with ablation, but the recurrences rates are high, and the patients who come with a late stage AFib, much more difficult to treat. And nobody, there's a lot of different theories. I don't think it's a disease that we'll ever be able to totally fix. The symptoms we're going to be able to placate and treat the symptoms well. We might be able to slow the progression of the disease, like you said, right, by preventing. And this is true for every kind of degenerative disease. We're finding out now, for cardiac disease in general, that if you, the more bad episodes you have, it tends to cause progression of the disease. So the more AFib episodes you have in a month, it's more likely that a year from now you'll have permanent AFib. The more episodes of congestive heart failure you'll have in a year, the same thing. You might end up on a transplant list sooner, or you might you might not survive for 5 years. So those kind of degenerative diseases, we used to think that the only reason to treat is to prevent the symptoms, but the truth is that by preventing these acute exacerbations, we're actually preventing progression of the disease.
Wow.
More importantly, even.
Well, I got to tell you, fascinating topic, and I know you're very busy, and I don't want to take up a lot more of your time, but I've got a question for you. When 5 or 6 years ago, there was a gentleman that I was talking with, and he had some heart issues, and his doctor said, maybe you should think about doing some walking or some exercise, and we were just talking as friends. And I said, well, what are you going to do about that? And he said, well, I believe that you only have so many heartbeats in a lifetime.
Yeah, I heard this before.
And if I get out there and use them all up by accelerating my heart, I'm not going to have as many, so I'm not too worried about exercise. What's your thought about that?
Well, if you train your heart, you bring down your resting heart rate.
That's right.
So exercising for 30 minutes and getting your heart rate up, if you change your resting heart rate from 80 or 90 beats per minute to 60, that makes all the difference in the world.
It's just a math problem.
It's just a math problem. But even if you believe in that,
yes,
if you train your heart and you reduce your resting heart rate, then you've made yourself you're going to be able to last longer, right?
Right.
So that's what I answer to that. And there is an obvious training effect, and we can all achieve it. We can all drop our resting heart rate easily by 10 beats a minute, 10 beats, from like 70 to 60 or 80 to 70, just by exercising for 6 months.
Right.
And then you have, years after that.
Well, I do enjoy the technology that you can monitor your heart rate and monitor certain physiological things that are taking place. And my resting heart rate is typically about 52. Right. So I think that's a really good resting heart rate. But seeing that feedback has allowed me to kind of focus in on what I'm doing and making my training more effective. So that I'm not just.
And there's a point of getting, of too much training too.
Sure.
Where it goes too low and then you get symptoms. So there is, we see that in marathon runners when they're very aggressive.
It's like stretching. You can be too flexible. You can be too trained for the heart. There's, as you've probably said a long time, moderation is kind of the key to everything. As long as you stay reasonable, then you'll get a benefit, but not go over the line. So.
Right. Don't injure yourself. Right. Don't damage. Don't make it worse.
Dr. A.
Okay.
Thank you very much for your time.
Thank you very much.
He's so good.